Hello and welcome you to the YouTube channel of Sree Balaji Medical College. I am Dr. Pugarendi, Professor of Orthopaedics, Sree Balaji Medical College, Chennai. This video lecture will be on osteomyelitis, one of the most common topic dealt in orthopedics for the undergraduates. In this video lecture, we will be dealing with etiology, pathogenesis, clinical features, and how to manage osteomyelitis will be dealt in detail. Now we will move on to the lecture. Osteomyelitis is classified into acute, subacute and chronic based on the duration of the symptoms. When the symptoms are less than 3 weeks of duration, it is said to be acute osteomyelitis, and if it is more than 6 weeks, it is chronic osteomyelitis. Osteomyelitis is an acute inflammatory process of bone caused by pyogenic organisms. It is commonly occurring in children and in adolescents. Adults can be infected when there is malnourishment and when the adults are in immunocompromised status. And adults can also be infected by direct inoculation of the organisms. So etiology, common organism causing osteomyelitis is Staph aureus. That is the main organism. About 70% of infection is by Staph aureus. And other organisms which can cause osteomyelitis are Staph aureus, pneumococcus. Haemophilus is a common organism found in children. And specific osteomyelitis can be caused by specific organisms like Salmonella and Mycobacterium tuberculosis. Common routes of infection are hematogenous. This is the most common route, where the source of infection will be somewhere else in the body, like ENT infection or skin infection or dental caries. From there, the organism gains entry into the bloodstream, and through the bloodstream, it can reach the bone and cause infection. And direct inoculation is another method of infection, where in case of open fractures, organism gains entry into the bone and causes osteomyelitis. And post-operatively, when any implant surgery will act like a foreign body and can cause osteomyelitis. The stages of osteomyelitis can be divided into stage of inflammation, suppuration, necrosis, new bone formation and resolution. So these are the stages of osteomyelitis, acute osteomyelitis. The infection begins in the metaphysis. Metaphysis of long bone is the commonest site where the infection begins. Because of the peculiar arrangement of the blood vessels in the metaphysis, organism spreading through the blood will get lodged in the metaphyseal region and the inflammatory process sets in. Once the inflammatory process sets in, within a couple of days, abscess formation, pus formation will happen, and this abscess will spread through the medullary canal, through the avation canals, and it can also pierces the cortex and forming a subperiosteal abscess. Elevating the periosteum, it can form subperiosteal abscess. And the abscess can burst out from the periosteum, and it can form a sinus and drain into the skin. In an attempt to repair this inflammation, a new bone formation will be present in the periosteal region, and this new bone, which is formed in case of infection, is called as involucrum. And pus draining out from multiple openings in the involucrum is called as cloaca, And because of circumferential abscess formation, both the medullary canal and in the subparietal region, the cortex becomes necrotic. So, and necrotic bone is called as sequestrum. So this is a picture showing the peculiar arrangement of the blood supply in the metaphyseal region. So there will be hairpin-like arrangement in the metaphysis, and because of this stagnation in the blood flow, the organism gains entry into the metaphyseal region. In children, growth plate will act as a barrier so that the epiphysis is not involved and the infection doesn't spread to the epiphysis or does not involve the joint. Whereas in infants, metaphyseal infection can easily spread to the epiphysis and it can involve the joint. So this slide shows the pathological process of the osteomyelitis. So metaphysis is the initial site of infection, and because of the inflammatory process, pus formation happens in the metaphyseal region. This pus travels through the medullary canal towards the diaphyseal region, and it can also pierce the cortex and forms the subparietal abscess. And this subparietal abscess elevates the periosteum, and this will be seen as a periosteal reaction in the X-ray. And as the disease progresses, the abscess will burst out through the soft tissues and will present like a sinus. As I said earlier, in stage of necrosis, because of the increase in the intercompartmental pressure and thrombosis of blood vessels, necrosis of cortex happens, and necrotic bone is called as sequestrum. And in an attempt to repair this inflammation, periosteum goes on producing a new bone, which is called as involucrum. Unless the sequestrum is removed, sequestrum will act like a foreign body and sinus formation will persist. Multiple sinuses will happen, and the pus travels through the soft tissues and open on the surface of skin as sinuses. And these sinuses will be adherent to the bone, which indicates the infections started from the bone. So adherent sinus is a pathological feature of osteomyelitis. Clinical presentations, children are more commonly involved and boys are more commonly involved because of their increase in activity. Usually there will be history of trivial trauma will be there, which will attract the attention. And pain is the most predominant clinical feature. Patient will present with fever and restriction of the movement in the affected limb. It's called as pseudo paralysis. Sometimes if the organism is highly virulent, child will present with toxic features like chills, rigors, generalized body pain, which are features of septicemia. Signs of osteomyelitis will be high fever and tachycardia will be there, and affected region will be red and warm, and affected bone will be swollen and it will be very tender. A restriction of movement of that affected limb will be there, and sometimes if the metaphyseal region is intra-articular, the joint may be involved, causing septic arthritis. Investigations, the blood count, total count will be elevated, and inflammatory markers like ESR and CRP will be elevated. In acute stage, hemoglobin may be normal, and in the chronic stage, hemoglobin will be decreased. Blood culture will be useful to detect the organism, and X-ray will be normal for the first 1 week or 10 days. Only after 10 days, periosteal reaction will be seen, and in the initial stages, technician bone scan will be helpful to identify the infection, and the ASO titer will be elevated. If there is pus has to be aspirated and sent for culture sensitivity, which will show the organism, and the organism can be isolated and appropriate antibiotic can be started. So this X-ray picture shows the stages of osteomyelitis. The first picture shows does not have any positive sign. The second picture shows the rarefaction in the metaphyseal region of the tibia. And the third picture shows the periosteal new bone formation. So this will take at least a week or 10 days for this to appear. Treatment of acute pyogenic osteomyelitis. Complete bed rest and IV fluids are started. These are important supportive measures, and analgesics and antibiotics are given. And usually broad spectrum antibiotics are started immediately as soon as infection is diagnosed. And if there is pus and if it is aspirated and organism is isolated, then appropriate antibiotics are started and high doses of antibiotics are given. Usually for acute osteomyelitis, 6 weeks of antibiotics has to be given. Initial 2 or 3 weeks IV antibiotics should be given, and then when the acute infection clinical picture settles down, you can switch over to oral antibiotics. Until the inflammatory markers come down, when the ESR and the CRP come down, the antibiotics are continued. So along with this antibiotic, splinting of the affected limb has to be provided to give rest to the part. And when the aspirate shows a thick pus, then it has to be surgically drained. Surgical drainage of abscess is very important to prevent further complications. And under anesthesia, the affected region has to be incised and subperiosteal abscess has to be drained. And if there is a subperiosteal abscess, multiple drill holes are made in the cortex so that the medullary abscess is completely drained. After the surgical drainage of the abscess, proper splinting of the limb has to be done, and along with that, antibiotics has to be continued. If the infection is properly diagnosed at the initial stage, further complications can be prevented. So complications of acute pyogenic osteomyelitis are septicemia. If the organism is highly virulent or the host resistance is less, then patient can develop septicemic features. And if the pus is not drained properly, then it can proceed to chronic osteomyelitis. And since metaphysis is the commonest site where the infection starts, when the physis or the growth plate, if it is involved, it can cause a deformity or shortening of the limb. And sometimes in specific regions like proximal femur or proximal humerus, metaphyseal region is intracapsular, so that metaphyseal infection can easily involve the joint causing septic arthritis. And pathological fracture can happen in a diseased bone. So these are the common complications of acute pyogenic osteomyelitis. Subacute osteomyelitis is caused by less virulent organism or in a highly resistant host. The clinical features will not be as severe as in acute pyogenic osteomyelitis. Patient may have mild pain and mild fever, and swelling will be there, mild tenderness will be there. X-ray will show a osteolytic lesion in the metaphysis of the long bone with a dense sclerotic margin. So this is X-ray picture of subacute osteomyelitis in the proximal femur and the distal tibia. It's called as Brody's abscess. And treatment is drainage of the pus and thorough curettage of the cavity. Differential diagnosis of osteomyelitis are osteoid Ewing sarcoma. Ewing sarcoma is a primary malignant bone tumor which can mimic osteomyelitis, so it has to be properly diagnosed and treated accordingly. So other differential diagnoses are osteoclastoma, tuberculosis, and eosinopenic granuloma. Chronic osteomyelitis. Usually it is a sequelae to acute osteomyelitis, or in the adults it can happen because of open fractures. When there is an open fracture, when the bone is exposed to the external atmosphere, organism can gain entry directly into the bone, causing osteomyelitis. And sometimes post-operative osteomyelitis can happen. Features of chronic osteomyelitis: so when the infection persists for more than 6 weeks, it is said to be chronic osteomyelitis. And because of repeated infection and acute exacerbations of the chronic infection, the affected bone will be thickened, irregular, and the bone may be deformed. In case of prolonged infection, the bone may be deformed. Multiple sinuses and scars will be there, and the sinuses may be discharging pus along with spicules of bone. Bone spicules coming out of the sinus is a characteristic feature of chronic osteomyelitis. And X-ray will show sequestrum lying in a cavity. This is X-ray picture of chronic osteomyelitis showing a dense sclerotic bone. That is a sequestrum lying in a cavity. Necrotic bone will be more denser when compared to the adjacent normal bone because of the decalcification process not taking place in the dead bone. And you can see the postoperative infection in the second slide, and osteolytic lesion in the distal tibia. So presence of sequestrum, that is dense bone lying in the cavity, is a characteristic feature of chronic osteomyelitis. Investigations, X-ray will show sequestrum, and the sinogram will be helpful in identifying the sinus tract. Radiopaque dye is injected through the sinus opening, and the entire tract can be visualized, so that during the surgical procedure the sinus tract has to be excised along with the sequestrum. Treatment for chronic osteomyelitis is sequestrectomy, that is the removal of the sequestrum, and saucerization. Sequestrum lies in a deep cavity, so the cavity has to be de-roofed so that the deep cavity is converted into a shallow cavity, so that the further accumulation of pus is prevented. This is called as saucerization. So treatment is sequestrectomy and saucerization. Next we move on to septic arthritis. Arthritis is inflammation of the joint caused by infective pyogenic organism. Again, the commonest organism causing septic arthritis is Staph aureus, and hemorrhaginous spread is the commonest route of infection. In case of infants, neonates, umbilical sepsis can cause septic arthritis in the hip joint. The common joints which are involved in septic arthritis are hip, knee, and shoulder. And once the inflammatory process is started, the synovium will be inflamed, and exudate will be formed in the joint. This exudate, inflammatory exudate produced by the synovium, will consist of proteolytic enzymes which will destroy the articular cartilage along with the bacterial toxins. This will destroy the articular cartilage, and this exudate may be serous, seropurulent, or seropurulent. Serous will be mild infection, and seropurulent will be severe infection caused by highly virulent organism. Stages of septic arthritis: we have stage of synovitis, stage of reversible arthritis, stage of irreversible arthritis, and stage of ankylosis. In the initial stage, only when the synovium is involved, it's called a stage of synovitis. Only the synovium will be inflamed, edematous, and hyperemic, and there will be inflammatory exudate in the joint. The articular cartilage will not be affected, and the X-ray will show increase in the joint space. The next stage, when the disease progresses, the inflammatory exudate and the bacterial toxins will destroy the articular cartilage. So the next stage will be reversible arthritis, where the X-ray will show mild destruction of the articular cartilage and irregularity in the joint surface will be seen. As the disease progresses, there will be complete destruction of the articular cartilage and exposing the subchondral bone. So that is the stage of irreversible arthritis. Finally, the end result will be ankylosis. That is, pathological fusion of a joint is called as ankylosis. The final end result of septic arthritis caused by pyogenic organism is always the ankylosis. and during the illness, patient will keep the limb in the position of ease. For the hip joint, the position of ease is flexion, abduction, external rotation, and for the knee joint, it is flexion. So these, for each and every joint, there is a position of ease so that maximum amount of synovial fluid can be accommodated. Clinical features of septic arthritis: the patient will present with severe pain and swelling of the affected region. All the signs of inflammation will be there: warmth, redness, severe joint tenderness, and movements of the joint will be severely restricted. So this picture shows stages of septic arthritis. So in the initial stage, only the synovium will be involved. In the stage of reversible arthritis, the cartilage will be damaged, showing irregularity in the articular cartilage. And in the stage of irreversible arthritis, there will be complete destruction of the articular cartilage, exposing the subchondral bone. Finally, the end result will be a ankylosis, that is pathological fusion of the joint. This X-ray picture shows the irregularity in the articular cartilage with joint space narrowing. Treatment is septic arthritis. As soon as you diagnose septic arthritis, it becomes an emergency treatment. Immediately, the joint has to be drained out. First, if the joint aspirate shows any purulent pus, then arthrotomy and drainage of abscess has to be done. Arthrotomy is surgical opening of the joint. When the joint aspirate shows a frank pus, immediate arthrotomy is to be done to prevent all the major complications like ankylosis or pathological dislocations. And appropriate antibiotics are started, and the affected limb has to be rested in a splint or a traction. And antibiotics, as in osteomyelitis, it has to be continued for 6 weeks until the inflammatory markers levels are normal. And aim is to prevent major complications like ankylosis. If the child or if the patient presents at a later stage when the articular cartilage is damaged, our aim is to promote ankylosis in a functional position. In summary, what we have seen in this lecture is types of osteomyelitis, that is acute and chronic based on the duration of the symptoms, and most common organisms, Staph aureus, causing the osteomyelitis, and hematogenous spread is the most common route, and pathological process like superficial abscess and circumferential abscess leading to necrosis of bone, and the common clinical presentations about pain, swelling, and restriction of joint movement with fever. And X-ray picture will be seen only after 10 days of infection that we have seen in this lecture. In the initial stages, technician bone scan will be helpful in identifying the infection. And the treatment is surgical drainage of the abscess and antibiotic coverage for at least for 6 weeks has to be given. For initial 2 weeks of IV antibiotics, and then switched over to oral antibiotics. For bone infection, we have to give at least 6 weeks of antibiotics. And in case of chronic osteomyelitis, presence of sequestrum is the pathognomonic feature, and treatment for chronic osteomyelitis is sequestrectomy and saucerization. So this is what we have learned in this video presentation. I hope this will be useful for your examinations and learning purposes. Thank you.